And just to quickly show you what happens as an example in women, if you take pubertal girls, formation is more than resorption, so the net balance is good. When you take, premenopausal women, resorption is already taken, over a little bit, and so the net balance is already down a little bit. But in postmenopausal women, clearly the resorption is more, so the net balance is much lower. And I'd say premenopausal women here, you could think of it as more like a perimenopausal women are in the, years before the menopause. And we know that as people get older, age is a really important risk factor for fractures, osteoporosis. So for the same bone density, if the person is in their 70s or 80s or 90s, their risk of fracturing is much more. And fracture risk increases in people with diabetes. In our country, for 100 million people with diabetes, uh, there is a very high risk of osteoporosis and fractures, not only due to bone quality and bone mass being lower, also because the advanced glycation end products as other changes that happen during with diabetes affects the bone quality. Plus, retinopathy, neuropathy, and other issues, sarcopenia, increase of your risk for fractures. Another risk factor is obesity. We always thought that obesity was protective of uh, osteoporosis because there was insulin resistance and insulin was anabolic and there was probably a little bit more averaging. So we thought obesity was protective. But now we understand better that the cells go only to the pre-adipocyte and the adipocyte, and less of it will be osteoblasts. So actually, obesity is a risk factor. So if you take the pathogenesis of osteoporotic fractures, so many things, postmenopausal bone loss, age-related bone loss, other risk factors we have talked about, starting with low peak bone mass, poor bone quality, uh, and non-skeletal factors like propensity for falling. Someone has dizziness, hypoglycemic episodes, they are more likely to fracture. So this all contributes finally to a fall and a fracture. So this fall is a very important thing because if you really think about it, if one does it all, chances of fracturing are less unless they zip, sustain heavy, and there are vertebral fractures happening. So if you just look at fracture facts, like a lot of fractures happen per year. The IOH says 2 million bones break in a year, 2 million too many. And one in two patients with osteoporosis gets a follow-up test or treatment for osteoporosis, which means 8 out of 10 patients who don't, and fracture will have serious consequences. Uh, and hip fractures, 10 to 20% additional mortality per year, and 20% of the fracture patients require long-term nursing home care. And all you can look at it is they need assistance even for their daily activities. And only 40% or so fully regain their pre-fracture level of independence. When you take osteoporosis in India, uh, public and physician awareness about the disease and its impact continue to be low in our country. The norm had believed that osteoporosis is a disease of the West and does not exist in India. The notion that osteoporosis is an inevitable consequence of aging, which can neither be treated nor prevented. Preoccupations of the health players with other conditions, infection disease, other non-communicable diseases, limited availability of diagnostic facilities across the country, and paucity of epidemiology data. I wouldn't really say this because I think plenty of research has been done in our country on normative data, on epidemiologic data. still note them. And we know that patients with a